Hi everyone. So this is the last section of the endocrine lecture. So thank you for listening to all the videos. And again, if you have any question, make sure to jot them down and then ask during the case conference on Thursday. And also feel free to email me with any question or any extra follow-up things. So adrenal gland disorders, it's not as common as either hypo or hyperthyroidism, and you're not gonna probably see them as much. So I'm really trying to focus on things that you would need to know as a community pharmacist or pharmacist in general. So we're a little bit staying. We are not going to spend as much time really talking about the disease state is themselves, but I want to really focus on the use of corticosteroids and when we use it in our practice, it's not usually for adrenal gland disorders. It's for other things like inflammation. So let's go over them and then see what we need to really counsel our patients and what we need to really know in order to manage our patients who may be on corticosteroids either long term or short term. So first, I just want to refresh you guys that within the adrenal cortex, they make three different types of steroids. So there are different sections. Within adrenal cortex, they make different types. So, for example, glucocorticoid is made, and then the main form is cortisol, and then mineralocorticoid is also made, and then the major form is aldosterone, and androgen, which is sex hormones such as testosterone and estradiol, is produced. So the glucocorticoid is what we're going to talk about the most, and it is made by the middle section of the adrenal cortex, which you guys may remember from anatomy. Zona vesiculata is the middle section. You don't have to really remember the name, but it's what it is. And then um, zona reticularis, which is a bottom part that makes adrenal androgens, and then the top part, which is the zona glomerulosa, makes aldosterone. So just remember that there are three different parts of the adrenal cortex that make different types of steroids. And then they all have different function. So, for example, corticocorticoid, glucocorticoid, uh, its main function is really regulate fat, carbohydrate, and protein metabolism, as I wrote here. And then mineralocorticoid, they regulate electrolytes and volume homeostasis, and it is regulated by rest system. And then the sex hormones are basically they influence reproductive system and then also modulate primary and secondary sex characteristics. So they all have different functions by binding to each respective receptors. So now when we look at the different types of different corticosteroids that are available commercially, so the short-acting ones, hydrocortisone and cortisone, they are the naturally occurring forms of corticosteroids. So they are short in duration, about 8 to 12 hours, and then they have affinity to both glucocorticoid receptor and mineralocorticoid receptors. So depending on their affinity to each receptors, they're going to exert their activity, whether it is glucocorticoid activity or mineralocorticoid activity. So, for example, hydrocortisone and cortisone, they have almost similar affinity to either receptors. So they are going to exert both glucocorticoid and mineralocorticoid activity, and mainly glucocorticoid activity is anti-inflammatory effect, whereas mineralocorticoid activity is sodium retaining effect. So those are short-acting corticosteroids. Now, so of course what we do in our medical chemistry world, you modify some of the functional groups to really modify their duration of action, their affinity to receptors. So they're trying to make it more of what we want from the drugs. So prednisone, methylprednisolone, triamcinolone, those are and fludrocortisone are considered intermediate acting ones. So those are synthetic corticosteroids that we modified to make it longer acting and more increased affinity to glucocorticoid activity and less of a mineralocorticoid activity. So we use prednisone the most in oral form, and they have about 4-to-1 ratio in glucocorticoid and mineralocorticoid activity. So it still has some mineralocorticoid activity, but it's not gonna have as much activity compared to hydrocortisone or cortisone. And one thing to note is fludrocortisone is mainly mineralocorticoid activity is what this drug exerts. So this is used only when we really need to replace and give more of a mineralocorticoid. So it's not really used for glucocorticoid activity. So it's more for mineralocorticoid. And there is no equivalent dosing given because this equivalent dosing is based on how much anti-inflammatory effect each drugs exerts. So they are really comparing anti-inflammatory effect, nothing to do with mineralocorticoid. That's why there is no equivalency given for fludrocortisone. And lastly, the longest acting ones, long-acting corticosteroids, are betamethasone and dexamethasone. So they do not have any mineralocorticoid activity. So when you need drugs that does not exert any mineralocorticoid activity, but just pure anti-inflammatory effect, these are the drugs that you can use. All right, so so you may see that this HPMD and 2541. So this equivalence dosing is something that you need to know that there are, if in case the patient needs to be switched from one corticosteroid to another, then you need to know that what is a conversion dose, and then you need to give an equivalent dose. So you can see 20 milligrams of hydrocortisone is same as 5 milligram of prednisone and everything else. But you're not gonna remember everything. But what you can remember is 4 most common corticosteroids. So as you all know, I love any types of mnemonics that really help us to memorize certain things. So HP, history and physical, is written by MD, medical doctor. So 20 divided by 5 is 4, and last one is 1. So hydrocortisone, prednisone, methylprednisolone, and then dexamethasone. So you can at least remember these 4. So usually these are the most common, one of the most common corticosteroids that are used in practice. So you can at least remember these conversion vectors on top of your head without having to look into the table for every single time. So we'll have practice question in the next page. So keep that in mind. All right, so there are some common adverse effects that we should be aware of for corticosteroids. So any drugs we give to our patients, we use them for good effect, but you know that there are going to be some unwanted adverse events that we have to be aware, so we can counsel our patients and educate them for those. So again, we have really nice mnemonics for us to help us to remember them. So prednisone is a mnemonic. So P, psychosis. So psychosis can happen with either short-term use or long-term use of corticosteroids. So usually if we use high-dose short-term use of corticosteroids, it can lead to more like a manic state of psychosis. And then when we use a low-dose long-term chronic use of corticosteroids, can lead to more depressive symptoms. And psychosis, if it happens, that really warrant the abrupt cessation of corticosteroids. We'll talk about it later. Usually, corticosteroids, especially long-term use, we have to taper it down. But when patient develops psychosis, especially manic state, we may have to just abruptly stop the corticosteroids. Our retention of fluid, edema, hypertension, it is mainly from mineralocorticoid activity. So we need to monitor a patient's fluid retention and hypertension, so blood pressure. And then we may need, if patient has a lot of this happening from corticosteroids, we will have to prefer the corticosteroids that has less mineralocorticoid activity over the other. Next one, weight gain. Kind of try to fit it in. So it can be from fluid retention, and also patients taking corticosteroids tend to gain weight. They're going to be increase in appetite, and and then remember that glucocorticoid is regulating metabolism of fat, carbohydrate, and protein. So there is some disruption in that metabolism, which lead to weight gain. And diabetes, really the glucocorticoids that increase gluconeogenesis, which increase hepatic production of glucose, which can exacerbate diabetes, or in general, it really raise fasting blood sugar. And no menstrual period. Remember that adrenal cortex produce all three steroids. So when there is some a lot of exogenous corticosteroids that can lead to some interference with sex hormones as well, androgens. So that can lead to some disruption of those androgen and those metabolism. Infection is something, so of course when we use corticosteroids that has anti-inflammatory effect, it will affect our immune system, and it'll cause immune suppression. And immune suppression is known to occur with high dose and for long-term duration. So we can figure out that any corticosteroid equivalent to prednisone 20 milligrams daily dose for longer than 2 weeks. When patient has been on it for this, we can assume that patient is immune suppressed. And when we can apply this is really in community practice setting. We cannot give live vaccine for those patients who are on this long-term high-dose corticosteroids. So this is because when patient is immune suppressed, there is a concern of safety of vaccination by giving live vaccines, and also we know that there is reduced immune response to the vaccine. So when we give live vaccine, it's not gonna give them. It may cause them infection from it, but also patients are not going to get enough immune response really to get the full benefit. So now, so this is actually one of the questions that is always on the immunization questionnaire. So when patient has been on this and they're done, so they are stopped taking corticosteroids, now you have to wait at least 1 month after discontinuation of corticosteroids to be able to give live vaccine. So now, what if patient is given live vaccine, and can we start high-dose corticosteroid therapy right away? For that case, theoretically, we want to wait at least 4 weeks, again 1 month after giving a vaccine, or 2 weeks after an inactivated vaccine to start the corticosteroid therapy. But again, if it's an urgent situation that we cannot wait, then we need to initiate the therapy. All right, stomach. So peptic ulcer disease can happen, and of course, corticosteroids increase the risk for ulcer, but it is more of a concern when patient is on corticosteroids and NSAIDs together, and they will cause synergistic effect and cause really increase the risk for peptic ulcer disease a lot more. And this is a case when we may need to consider giving patient PPI prophylaxis to kind of protect their stomach. And all osteoporosis can happen because corticosteroids increase bone resorption, so that cause less of a bone, so it'll cause osteoclast, which can lead to less bone mineral density, which can cause bone fracture. And sodium retention is again from mineralocorticoid activity, and eyes, it can cause or exacerbate cataracts and glaucoma in patients. So if patients already have these conditions, especially in older patients, we have to be careful with the drug therapy. All right, so remember prednisone. All right, so let's do a practice question for dose conversion. So patient is taking prednisone 30 milligram daily and is experiencing peripheral edema. Which glucocorticoid would you suggest to switch to and why? So you remember prednisone is a intermediate acting corticosteroids that has more anti-inflammatory glucocorticoid activity, but then it still has some mineralocorticoid activity in about 4:1 ratio. So because of that, this patient is experiencing peripheral edema, so sodium retention and fluid retention leading to edema is one of the side effects from mineralocorticoid activity of corticosteroids. So which glucocorticoid would you suggest to switch to and why? So in this case, it would be preferable to give corticosteroids that does not have any mineralocorticoid activity. So in this case, dexamethasone will be a good choice. Remember, there is two long-acting corticosteroids, betamethasone and dexamethasone, and dexamethasone is a one that is available in oral form that is most commonly used in outpatient setting. So now calculate appropriate dose of the alternate glucocorticoid. So remember HPMD, history and physical is written by MD. 20 divided by 5 is 4, and last one is 1. So prednisone to dexamethasone ratio is 5:1. So 5:1 equals 30 milligram to what we want to find out, the new dose. So 30 divided by 5 is 6 milligram dexamethasone is the right answer. All right, so this sounds like it's gonna be a question that can be asked in the exam. So make sure you remember these HPMD and then remember how to do the calculation for the new dose. All right, principles of glucocorticoid administration. So normal adult produce approximately 10 to 30 milligram of cortisol per day. So this is how much we have naturally in our normal body. And then their peak concentration occurring around 8 a.m. Remember that all the counter-regulatory hormones such as cortisol, growth hormones, glucagon, those are all made overnight. So that was what's causing things like dawn phenomenon, right? Remember that from diabetes section? So they start rising from like midnight all the way through the morning, and it's peaking at 8 a.m. And from that point, it'll come down, and it's gonna be the bottom nadir point at midnight, and the cycle begins again. So it really follows our circadian rhythm. So that's why glucocorticoids is really recommended to be taken in the morning to really mimic our physiologic rhythm. So especially when we are giving corticosteroids to replace for adrenal gland disorder, especially adrenal insufficiency, that we're replacing naturally occurring cortisol level, then we have to give it in the morning to really mimic our physiologic rhythm with cortisol level. And also corticosteroids can cause insomnia when it's taken at nighttime, so it is really to be avoided to be taken and then taken in the morning. And give the lowest dose that will manage the disease being treated for the shortest possible duration, which is common sense, because like what we just saw with the prednisone mnemonics. When we give too excess amount of it, it causes a lot of adverse reaction, and then we'll look at that later. It'll cause